Welcome to the TFPHN training on a trauma-informed care approach. Specifically, this video is intended to help you apply as a home visiting team trauma-informed care. There are many types of trauma-informed care models. For example, there's the Center for Healthcare Strategies 10 key ingredient model. There's the Harvard program in refugee training that has 5 H's surrounded by the trauma history. There's also the Agency for Healthcare Research and Quality model, which is a trauma-informed care pyramid that helps practitioners visualize trauma-informed care and how to apply the principles to practice. What's most important is that when you're using trauma-informed care approach, you choose a model that works for your particular needs. For the TFPHN model, we chose the Substance Abuse and Mental Health Services Administration 6 guiding principles in trauma-informed care. I'd like to explain to you the 6 guiding principles as they apply to home visiting. But first, let's just review what the 6 principles are. Safety is the first, followed by transparency and trustworthiness, collaboration and mutuality, empowerment voiced in choice, peer support, and finally, cultural humility or cultural, historical, and gender issues. Now let's look at each individual component and see how that applies to home visiting. So as we go through these slides, I'll be explaining how safety and all of the various principles apply first to the client and then next to the staff on the TFPHN team. How does safety apply, or what does safety feel like for the client? First, it means that confidentiality is maintained so that when you provide your client a release of information and explain the confidentiality programmatic principles, you adhere to those. It also means being welcome. It means there's no judgment. Here's a concrete example for your home visiting team to ponder. In the words of the client, I told the home visitor that my boyfriend hit me. She listened and didn't judge me. We made a plan in case I needed to leave immediately. This is an example of how safety can feel for a client in TFPHN trauma-informed approach. What about safety for the home visitor? Well, that means feeling supported in your decision-making, being included, having good intent assumed. So let's look at a concrete example. I've been trained on how to exit a situation if and when I feel unsafe. It's important that every home visitor and every organization ask themselves if they are minding and tending to the safety needs of their staff. Let's next look at the principle of transparency and trustworthiness. What does that look like to the client? First, it means an open and honest communication exists, and that there's follow-through from that home visitor to the client. Here's a concrete example. My home visitor told me she was a mandated reporter at the first visit. So when I relapsed and needed help, we called CPS together. I felt like I could trust her to support me. I know from experience as a home visitor and a supervisor that cases in which clients are aware of your mandated reporter status right from the enrollment and included in the decision to report are more likely to get a better experience with their case in Child Protective Services. Now, we also know that that's not always possible, but this is a good example of how trustworthiness and transparency can exist. How about for the staff? What does transparency and trustworthiness look like to the public health nurse, social worker, community health worker, and even the supervisor? Well, here's a concrete example. The new client assigned to me is my friend's daughter. I told my supervisor right away, and the case was reassigned. Obviously, living and working in a rural area makes it more challenging to maintain those boundaries of knowing people in the community directly. But whenever possible, we should definitely identify when there is a conflict. Here's an example from a supervisor. I trust my team to only look at the health records of their clients. This is really important that although we may look at other records for training purposes, that we keep the confidentiality, that we maintain that trust to our clients and to our cohort of clients. Next, peer support. What does peer support mean for the client? Well, it can mean friendships, family, parent-related blogs or other social media sites, opportunities to participate in groups. Here's an example of a grassroots organization that is over a decade old and is in many communities throughout the United States, the Parent Cafe. This is an excellent way for parents to even meet virtually now. And here it is advertised on Facebook, which is another example of a possible way for parents to socialize, even in the midst of this pandemic. But what about peer support? What does that mean for the public health nurse, social worker, community health worker, and supervisor on the TOPHN team? First of all, it means an open door policy. That is really important for especially the management, leadership, supervisor to maintain. Maintaining commitments to one-on-one time. And then also weekly case conferencing. By attempting to create an atmosphere of collegiality, we're giving each other support in a very difficult and challenging role as home visitors. This is important to maintain our understanding, our empathy with the clients and each other. This is another example of how you might use a template for case conferencing that follows the Gibb cycle. This is a reflective cycle or process that we'll explain a little later. What about collaboration and mutuality? How do we incorporate these for the client? Well, including the clients in decision-making and asking, listening, and remembering can contribute to collaborating and being mutual with the client. Here's a concrete example. My nurse showed me the care plan and asked if there was anything I wanted to add or take away. Ask yourself, how often do you actually share the care plan, action plan with your client who should be at the root of decision-making on what goes on to that plan? Here's an example of how we can incorporate collaboration and mutuality for the TOPHN staff. We want to be mindful that your organization should be more grassroots versus top-down and encourage and promote creativity. So in the words of a staff member, we got approval to develop a focus group for the clients so that they can be part of our planning. This is a win-win, a double example of collaboration and mutuality, because this one also includes client and team members. The next component is empowerment, voice, and choice. What does that look like for the client? First of all, it should mean that all services are voluntary. The client should be able to enroll and exit the program when he or she wants to, and not feel coerced or forced into signing up. They should also know that if the case manager is not a good fit, it's okay to ask for a change. Here's an example from a client that I had. I told the home visitor I got everything I needed. I'm done with having the home visits for now. And in this example, you might not have a client who you feel is ready to exit telling you that they are ready to exit. But what's most important is that they have the voice and choice to tell you when they're ready to exit. What does empowerment, voice, and choice look like for you, the public health nurse, social worker, community health worker, or supervisor? First of all, it means that we have an egalitarian versus hierarchical structure, and that there's opportunity for advancement based on merit. Here's a concrete example from a team member on our Sonoma County team. I disagreed with a colleague and my supervisor in a meeting. and my opinion was heard. I felt like that was okay now. And finally, let's look at cultural, historical, and gender issues as they impact the client. I'm first going to show you a concrete example that may seem rather negative, but this is an example where we can definitely learn. I'm a dad. All of the papers I've signed from the nurse say maternal child, but they haven't had too many cases like mine. In this case, this father is not feeling included. And I think it's really important that we review all of the literature, handouts, and documents within our organizations so that we can ensure that we're being inclusive. Well, here's another concrete example of a client who felt included or heard. My home visitor asked which language I am most comfortable speaking. In this example, although the client may be fluent in English, they may feel more comfortable speaking in their native language. And it's really important that we listen to those cultural nuances. How do cultural, historical, and gender issues impact the public health nurse, the social worker, and supervisor? These are impacting on our attitudes, beliefs, assumptions, values, and experiences, and maybe at times seeming uncomfortable to explore as a team, but really, really important. So I think this example of someone who sees themselves in the brochure images, artwork, and workforce of the organization feels included. And that is for all cultural, historical, and gender areas. So now let's put some of these principles into practice. I'm going to show you some examples of where the Sonoma County team actually changed the way we did things by incorporating some of these trauma-informed principles. First, let's look at transparency. So we looked at how we were sharing goals and benchmarks with funders, staff, and leadership. And in this example of transparency, it was our logic model that we changed. So this may be an eye strain, but do remember that this logic model is part of our TIA PHN guidebook as well. In the logic model, we made very clear what it was we were assuming about the clients we serve and what external factors we had as challenges to meeting their needs. We also set goals that were very concrete so that we can then eventually evaluate ourselves and see whether or not we meet those goals and be transparent in the process about how well we met those goals. Here's another example, and this one is on peer support. So I said earlier that we would explain the Gibb cycle of reflection a little better. And in this example, I'm going to give you a skit or role play regarding a supervision, reflective supervision, that uses the Gibb's reflective cycle. As I go through the various parts of this cycle, I want you to pay attention to the supervisor and whether or not open-ended questions are used versus yes or no. So we'll start with description. What happened? What's the current challenge? The home visitor tells the supervisor, I had the most frustrating visit yesterday. My client Sarah texted me 15 minutes before our visit, asking if we could meet at the library instead of her apartment. The supervisor picks up with feelings. How did you feel and think about it? How did changing plans last minute make you feel? She asks. And the home visitor says, I felt a bit manipulated and less in control. Next, we move to evaluation. What was good and bad about what happened? So the supervisor asks, what was positive or negative for you? And the home visitor replies, I think it's good that she still wanted to meet, but I feel bad that she doesn't want me at her apartment. Maybe it's because she has a lot of roommates. You can see how they're both exploring this in a much more open fashion rather than assuming. And then we move to conclusion. What did you learn? What else could have been done? The supervisor asks, why do you think she kept the appointment instead of just canceling it? And the home visitor replies, well, it seems like she values our visits. Even though we were in a public area, she opened up about her low mood to me yesterday. And finally, we move to action. If it happens again, what would you do? The supervisor says, sounds like some really good insight. Well, would you do anything different next time she changes plans last minute? And the home visitor says, thanks. I'll be more prepared to shift gears and be open to what she's concerned about most in the moment. But I'll also be okay letting her know if I can't change plans. This example of a reflective supervision allows the home visitor and the supervisor to explore thoughts and feelings and next steps rather than advice giving that assumes. And as you noted, probably, there weren't any yes or no type questions. Now let's look at cultural, historic, and gender issues as an example. And this one shows a data collection change. For years in our county, we had been asking in our assessments how often the father of baby was involved and had a drop-down answers of daily, a few times a week, at least once a week, infrequent, no contact or not applicable. But it occurred to us as we were adopting this trauma-informed approach that perhaps this was a gender assumption about the co-parent that wasn't valid for all parents and didn't reflect, even among our staff, what parenting looks like. And so we changed this to other co-parents' involvement, not primary client. This was a simple change that allowed us to acknowledge that co-parenting is not always with a male-female couple, and also that the primary parent is not always the woman. So when thinking about adopting a trauma-informed approach, let's ask ourselves, what trauma-informed principles are we already following? Which would you like to develop or improve? And how motivated are you to change? And finally, how confident are you that you can change? So why does being trauma-informed matter? Well, we know that exposure to adverse childhood experiences leads to higher morbidity and mortality later in life. And we know that families able to lower toxic stress and optimize health will engage better with us with primary care and with supportive services. If we're able to engage with parents, it really means that we meet them where they're at as respectfully as possible. And dealing with a population that has a high prevalence of trauma requires a trauma-informed approach in meeting their needs. Thank you.